ಮಕ್ಕಳಲ್ಲಿ ಆಟಿಸಂ ಅನ್ನು ಅತ್ಯಂತ ಬೇಗನೆ ಪತ್ತೆ ಹಚ್ಚುವ ಹೊಸ ಕೃತಕ ಬುದ್ಧಿಮತ್ತ ತಂತ್ರಜ್ಞಾನದ ತ್ವರಿತ ಸಾರಾಂಶವಿದು. ನಮಸ್ಕಾರ, ನಾನು ನಿಮ್ಮ ಡಾಕ್ಟರ್ ದೀಪಕ್ ಚಿರೋಡೂನಿ ಮಾತಾಡ್ತಾ ಇದ್ದೀನಿ. ಭಾರತದಲ್ಲಿ ಆಟಿಸಂ ಪತ್ತೆ ಹಚ್ಚಲು ವರ್ಷಗಳೇ ಕಳೆಯುತ್ತಿರುವ ಈ ಸವಾಲಿನ ಸಮಯದಲ್ಲಿ ಏಮ್ಸ್ ಜೋಧ್ಪುರ ಪರೀಕ್ಷಿಸಿರುವ ಈ ಹೊಸ ವೆಬ್ಕ್ಯಾಮ್ ಆಧಾರಿತ ಸ್ಕ್ರೀನಿಂಗ್ ಯಾವುದೇ ದೊಡ್ಡ ಉಪಕರಣಗಳಿಲ್ಲದೆ ಆರಂಭಿಕ ಚಿಕಿತ್ಸೆಗೆ ಹೇಗೆ ದಾರಿ ಮಾಡಿಕೊಡುತ್ತೆ ಅಂತ ಇವತ್ತು ನಾವು ನೋಡೋಣ. ಮೊದಲನೆಯದಾಗಿ ಇದರ ನಿಖರತೆ. ಕೇವಲ 2 ನಿಮಿಷದ ವಿಡಿಯೋ ನೋಡಿ ಮಗುವಿನ ಬೆಳವಣಿಗೆ ಅಳೆಯೋಕೆ ಸಾಧ್ಯನಾ ಅಂತ ನೀವು ಕೇಳ್ಬೋದು. ಖಂಡಿತ ಸಾಧ್ಯ. ಮಗುವಿನ ಕಣ್ಣಿನ ಚಲನೆ ಹಾಗೂ ಮುಖದ ಭಾವನೆಗಳನ್ನು ಅಳೆಯುವ ಈ ಎಐ ತಂತ್ರಜ್ಞಾನ 100ಕ್ಕೆ 100ರಷ್ಟು ಕರಾರುವಕ್ಕಾದ ಫಲಿತಾಂಶ ನೀಡುತ್ತೆ ಅಂತ ಏಮ್ಸ್ ಜೋಧ್ಪುರದ ಸಂಶೋಧನೆ ಸಾಬೀತುಪಡಿಸಿದೆ. ಎರಡನೆಯದಾಗಿ ಪೋಷಕರಿಗೆ ನೆಮ್ಮದಿ ಕೊಡುವ ವಿಚಾರ ಅಂದ್ರೆ ಮಗುವಿನ ಆರಾಮ. ನೋಡಿ, ಇದು ಸಂಪೂರ್ಣವಾಗಿ ನೋವುರಹಿತ ಮತ್ತು ಸುರಕ್ಷಿತ ವಿಧಾನ. 16 ತಿಂಗಳಿಂದ 9 ವರ್ಷದೊಳಗಿನ ಮಕ್ಕಳು ಕೇವಲ 60ರಿಂದ 80 ಸೆಂಟಿಮೀಟರ್ ದೂರದಲ್ಲಿ ಕೂತು ಆರಾಮಾಗಿ ವಿಡಿಯೋ ನೋಡಿದ್ರೆ ಸಾಕು. ಯಾವುದೇ ಇಂಜೆಕ್ಷನ್ ಅಥವಾ ದೀರ್ಘಕಾಲದ ಪರೀಕ್ಷೆ ಕಿರಿಕಿರಿ ಇರೋದಿಲ್ಲ. ಕೊನೆಯದಾಗಿ ನನ್ನ ಸಹವರ್ತಿ ಮಕ್ಕಳ ತಜ್ಞರಿಗೆ ಒಂದು ಕಿವಿ ಮಾತು. ಇದನ್ನು ನಮ್ಮ ಕ್ಲಿನಿಕ್ನಲ್ಲಿ ಅಳವಡಿಸಿಕೊಳ್ಳೋದು ತುಂಬಾನೇ ಸುಲಭ. ಕೇವಲ ಒಂದು ವೆಬ್ಕ್ಯಾಮ್ ಮತ್ತು ಸ್ಪೀಕರ್ ಇರೋ ಸಾಮಾನ್ಯ ಲ್ಯಾಪ್ಟಾಪ್ ಇದ್ರೆ ಸಾಕು. ರೋಗ ನಿರ್ಣಯದ ವಿಳಂಬ ತಪ್ಪಿಸಿ ಅಗತ್ಯವಿರುವ ಮಕ್ಕಳಿಗೆ ನಾವು ತಕ್ಷಣವೇ ಆರಂಭಿಕ ಬೆಂಬಲ ಹಾಗೂ ಚಿಕಿತ್ಸೆ ನೀಡಬಹುದು. ಒಟ್ಟಾರೆಯಾಗಿ ಹೇಳಬೇಕಂದ್ರೆ, ಪೋಷಕರಿಗೆ ನೆಮ್ಮದಿ ಹಾಗೂ ವೈದ್ಯರಿಗೆ ದೈನಂದಿನ ಚಿಕಿತ್ಸೆಯಲ್ಲಿ ಅತ್ಯುತ್ತಮ ಸಾಧನವಾಗಿರುವ ಈ ಸರಳ ವೆಬ್ಕ್ಯಾಮ್ ವಿಧಾನ ನಮ್ಮ ಮಕ್ಕಳ ಭವಿಷ್ಯದ ದೃಷ್ಟಿಯಿಂದ ನಿಜಕ್ಕೂ ಒಂದು ಕ್ರಾಂತಿಕಾರಿ ಹೆಜ್ಜೆಯಾಗಿದೆ.
Human brain development relies on a strict biological schedule. For neurodevelopmental conditions, the critical window for intervention closes rapidly, with treatment efficacy dropping significantly after a child reaches 3 years of age. In India, the epidemiological reality is an autism spectrum disorder prevalence of 1 in 100 children. Yet the average age of diagnosis is frequently delayed to 4 or 5 full years, well beyond that optimal neuroplastic window. This delay stems from a severe bottleneck in tertiary care pediatric centers. Standard diagnostic tools like CARS-2, MCHAT, and the ISA are the current reference standards, but they require extensive observation time. Administering them demands highly trained specialists and exhaustive manual observation to evaluate a child's behavioral responses. In developing nations with high pediatric footfall, this manual workflow creates an unsustainable ratio. A very small handful of specialists simply cannot dedicate hours to every suspected case entering a high-volume clinical pediatric setting. Relying exclusively on resource-intensive manual diagnostic pathways ensures that operational scaling limits will lead to missed windows for early intervention. To address this capacity limit, a 6-month cross-sectional validation study was conducted at AIIMS Jodhpur to evaluate an automated solution. The core proposal replaces initial specialist observation with automated digital phenotyping. In this context, digital phenotyping means translating subjective behavioral markers into quantifiable, high-dimensional spatial data. This comparison shows the standard clinical path versus a 2-minute laptop webcam test. The AI model achieved an area under the curve of 0.9016 and 100% specificity. This screening requires no specialized eye-tracking hardware, just a consumer-grade laptop, its webcam, and speakers. If subjective behavioral markers can be reliably extracted using existing low-cost hardware, the specialist bottleneck is bypassed at the triage letter. The AIIMS Jodhpur protocol begins with a tightly controlled physical environment. The child is positioned at a standardized distance of 60 to 80 centimeters from the laptop screen. Maintaining this exact seating parameter is critical for consistent spatial mapping across different patients. The study transitioned from an older 4-minute stimulus to a highly condensed 2-minute audiovisual sequence. This sequence is not random. It consists of 9 distinct sequentially engineered modules designed to prompt specific clinical responses. These modules are built to elicit social attention, orienting to a name call, and affect recognition. At the same time, the system targets gaze allocation, joint attention, and visual motor tracking. Standardizing the physical distance and compressing the stimulus into these targeted modules creates a controlled environment for precise algorithmic observation. The system ingests the webcam feed for feature extraction. The software isolates spatial features, tracking continuous gaze coordinates, fixation patterns, and overall gaze distribution. It also extracts temporal features, measuring response latency to sudden auditory or visual shifts. This data is then processed by a convolutional neural network, or CNN. The CNN does not watch the video in a traditional sense. It processes the high-dimensional, temporally encoded spatial representations generated from the extraction phase. The model is trained to identify the subtle mathematical variances in these features that distinguish an ASD profile from a typically developing child. This process replaces human clinical intuition with the mathematical thresholding of microbehaviors. To validate these algorithmic predictions, researchers compared them against real-world diagnostics in a clinical trial. The cohort consisted of 61 children between 16 months and 9 years of age, enrolled consecutively to minimize bias. Clinical raters were completely shielded from the AI system's outputs to prevent incorporation bias. Each child was evaluated using a combination of MCHAT, CARS-2, the Ames Modified Inclen tool, and ISA, with the results serving as the gold standard reference. The validity of the AI pipeline rests on its ability to blindly match these comprehensive, multi-hour clinical assessments. This is the receiver operating characteristic curve for the 2-minute model. It achieved an area under the curve of 0.9016 against blinded clinical diagnoses. Breaking down performance, 51 children were correctly identified as true positives, yielding 83.61% sensitivity. The false positive rate was 0, meaning no misclassifications, yielding exactly 100% specificity. This high performance was consistent across age strata, maintaining its accuracy for children both under and over the age of 3. An AUC of 0.9016 indicates excellent discriminatory capacity, proving the 2-minute digital phenotype is a highly reliable proxy for manual evaluation. However, this data must be contextualized within the cohort's baseline distribution. The study analyzed 60 clinically diagnosed ASD patients and only one typically developing child. While the 100% specificity is significant, it reflects a dataset with high prevalence and a very small control group in a tertiary care setting. On an operational level, the system was highly successful. Tests were completed in under 5 minutes on average, with high compliance and 0 adverse reactions. This CNN pipeline is designed as an adjunctive triage layer, not a replacement for a definitive specialist diagnosis. By automating the initial behavioral screening process with a standard webcam, tertiary centers can filter out operational noise and drastically reduce diagnostic delays, ensuring specialists focus their time on confirmed at-risk children before the neuroplastic window closes.